Welcome to all of you in Missouri Auditorium for the Wednesday afternoon lecture, and also to those who are watching by the video connection. This is a special Wednesday afternoon lecture, the Margaret Pittman Lecture. Margaret Pittman, who you can see something about in the materials that I hope you picked up as you walked in, is a trailblazer at NIH. A legendary scientist who became the very first female laboratory chief at NIH, and in whose name we now hold this annual lecture, particularly featuring other women trailblazers, and today is a great example of that in the form of Lucille Adams-Campbell. I've known Lucille for, I think, about 20 years in one capacity or another, and just delighted to have her here today for the Pittman Lecture. She got her undergraduate degree and her master's degree at Drexel, and then her PhD at the University of Pittsburgh in epidemiology. As I understand, the first African-American woman to get a PhD in epidemiology at that institution at that time. Went on from there for a period at the New England Research Institute in Watertown, and then in 1990 came to our neighborhood, to Howard University College of Medicine, where she rose through the ranks quickly from associate to full professor with tenure, and a variety of other roles she had there: professor of community health and family practice, professor of psychology, professor of epidemiology. It kind of covered a lot of ground there, reflecting her considerable skills and expertise in a wide variety of areas. And then in 2009, after that long and very productive time at Howard, she moved over to Georgetown University Medical Center and the Lombardi Comprehensive Cancer Center as professor of oncology. She is also there as senior associate dean of community outreach and engagement, and she's the associate director of minority health and health disparities research at the Lombardi Center. Again, still wearing an awful lot of hats there, which reflects the fact that everybody wants Lucille to help them out with all of the important things that institutions are trying to do. She's been highly recognized for her work. She's an elected member of the National Academy of Medicine. She was elected to the DC Hall of Fame. And just last year, she was one of only 10 people chosen as Washingtonians of the Year by Washingtonian Magazine. I'm also glad to say that she's been well supported by NIH over the years, so we claim her in all sorts of ways, and also express appreciation for the way in which she has served in various capacities, including on the Board of Scientific Counselors for the National Human Genome Research Institute. Her areas of research have focused on health disparities, particularly health disparities affecting cancer that disproportionately affect African Americans. She's going to talk to you about a number of aspects of that. Her work has certainly laid out a lot of the issues that we all hope can not only be identified but addressed in terms of implementation of ways in which these health disparities, which should trouble all of us, can be actually turned into something that we could call past history instead of present reality. Her title today is A Community Approach to Breast Cancer Prevention, Addressing Health Disparities. Please join me in welcoming Professor Lucille Adams-Campbell.
Much, Dr. Collins, and I want to thank the nominating committee for selecting me for this lectureship. It is indeed an honor and privilege to come to NIH. I come a little bit regularly. I think they know that I live only about 8 minutes away when there's no traffic, so that's been easy on the pocketbook. They don't have to pay for too much. So as been said, I'm going to talk about a community-based approach to breast cancer prevention, addressing health disparities. My focus has always been on the biological basis of health disparities, and I do understand clearly that it's so important that we address access and socioeconomic status, many other things that address disparities, but I will show you how the people that we always say they're hard to reach. I don't think the population is hard to reach. I just think we need to take the attitude of we're the go-get-'em group. So we're going to have a little different focus from that perspective. Just want to show you here just a little picture about the 5-year rate changes. This is incidence rates for the different cancers, because I come from the cancer world. And I want you to know the green means that the cancers are decreasing, And the red means that the cancers are increasing. This is for the U.S. white population. But you look here, you see a lot of green, a lot of improvements. But when we look for blacks, you see quite easily that we have a significant amount of red. What's going on right there immediately? We think about, we hear the rates are declining. How come it doesn't decline for all? How come everybody doesn't benefit? And those are important questions that we have to continue to address. But we must make certain that we address those issues, because if you look at this slide of the projected cases of all invasive cancers in the United States, you'll see that by race, you'll see the black bar represents the blacks. It's increasing. Of course, you have the multi-ethnic groups, the way we're predicting it now, and we see the increase among whites. You see overall, we see more increase in blacks for cancers. But let's go a little step further. If you look at panels B and D in particular, if you look at it by age, over 65, you're going to see higher rates in the black population. But more importantly, down here, if you look at this group of minorities and a percent change in terms of the cancers over time, you see a much significantly greater increase in cancers among minorities than you see among the white population. And this is important to notice because people are interested in clinical trials, clinical studies, clinical research, but if everybody doesn't participate in those studies, everybody will not benefit. And you'll still have this great increase in minorities that are not being part of the solution. They're not a part of the problem. They just need to be incorporated to be part of the solution. So from 2010 to 2030, the total cancer incidence will increase from 1.6 to 2.3 million people. There's a 99% increase anticipated for minorities compared to only 33% for whites. That's very dramatic, very striking to know. And the percentage of all cancers diagnosed in minorities will increase from 21% to 28%. So is there something different? Is it biology? Is it genetics? Is it epigenetics? What is it that causes these problems? If you look here, you probably all know these data showing the 5-year relative survival rate by stage and also the stage distributions. In short, minorities have the worst profiles. Blacks have the worst profiles. But we get tired of it always being the worst for black populations or minority populations. So how do we turn that around? And I'm just going to take a little snapshot and look just in the Washington, D.C. area. And I think it's important to point out that for blacks, again, very high rates, but mortality is always higher. It's one thing to be diagnosed with a disease. Like you can get diabetes, you can live with diabetes. You can get hypertension, you can live with hypertension. You can get cancer. We have so many survivors nowadays that are cancer survivors, but it's not affordable and offered to everybody. And minorities are disproportionately impacted by cancer. Is it because of the stage of diagnosis? Is it because of the disease that's treated? Even if we look around and think about Washington, D.C., we have more hospitals closing in areas that service minority and poor populations. So that's not going to improve anything. And I do believe that for us to address the issue across states, across countries, every hospital, every healthcare has to take and play a role in addressing the disparities that we see today. So I get to my little slide about equality, equity, and reality. You hear people say we want equality for all. Well, do we really want the same size for everything? We're now in this era of precision medicine. We don't want just equality. We want equity. So here, look at the little equality box. Everybody has the same box. It's like everybody's given the same medicine. We know the same medicine doesn't work for everybody. Here, we talk about equity. At least if you have the appropriate size box, people can see out into the field. But here is our startling reality. People are often left in the trenches. They're left behind. And people didn't ask for this. It's just what happens. When I think about insurance companies at hospital settings, I think that if you, DC, Maryland, wherever you are, if I give you an insurance card, but the hospital doesn't take it, do you really have insurance? And sometimes you have to really stop and think about that. It's like water everywhere and not a drop to drink. I have my insurance. Oh, this hospital doesn't take that. So we have to get to a place where everybody has an opportunity to be treated humanely and equally. So I'm going to tell you about some of the health problems, but I want to just talk about community outreach and engagement for a while. The National Cancer Institute has created community outreach and engagement as an official component of comprehensive cancer centers. Well, I think I've been doing this before it was ever popular to do, and it's really so important that we are engaged in the community to address the community needs. There's no other way that it can be done. You can't sit in the Ivy Tower and address the issues in the community because you won't even know what the issues are. And here, even Georgetown has an office in Southeast DC, and we have outreach and engagement staff that are actively involved in addressing and assessing the needs of the community and trying to establish many partnerships so that we can solve problems and not tell people they're part of the problem. So my Office of Minority Health and Health Disparities Research addresses several issues: outreach, navigation. It's important that we navigate people where they have to go. Training, we have to train people at all levels, whether it's pre-doc, undergrads, graduates, medical students, in the field, in the area of health disparities. We do want to stimulate disparity science. We want to actively surveillance the cancer rates and also the risk factors. And it's really important that we maintain our Community Advisory Council. And interesting that Vivian Penn's symposium going on, and she was one of my members of the Community Advisory Council. We get people from all walks of life, and particularly from the community, from the residents that live in those areas that are most heavily affected. And we do population, basic science, translational research. And I think that's important for you to realize that when we talk about disparities, don't put it in a corner and say, well, that's about access. I don't do that. Think about what you can do to address the science that is leading to and resulting into these disparities. How do we minimize it? This is just our Community Advisory Council, and you'll see the Office of Minority Health. We sort of like coordinate and feed off of each other, from the community outreach and engagement and education, navigation to research. And the research cuts across, like I just said, very different aspects. And you have to do more team science and work together collaboratively to get anything, I think, successfully done. We don't just want one discipline focused on a project. We want to see a very multidisciplinary team so that we can address the issues appropriately, adequately, and with significant depth. We also have to make certain we listen to our community. And our community voices they inform our catchment area, which is Washington, Maryland, Virginia for the most part. But we work with DC Department of Health or the public housing residences. And it's really important that we work with the public housing residences because public housing always feels like they're left out. But they bring so much to the table. They bring so much to the table. Whether we have to explore their environmental conditions, because we know environment can lead to cancer. We know environment can lead to many other chronic diseases as well. But just giving you an example of how the community does inform our science, it helps us inform our science. It helps us keep our fingers on the pulse of the community. You know, I'm at Georgetown. Georgetown is in Georgetown. The rest of the community is out in the city, inner city, different parts of the world, literally. And the only way we can have dialogue is to be a part of the community. So at our office, we are part of the fabric of the community. So they're willing and they trust us and they work with us. And it's important to get people involved in clinical studies, which I'm going to talk about in a minute, and clinical trials. You often hear statements made, oh, they're not interested in being in studies. They're not interested in being in clinical trials. When the reality is, if you've never been invited or never been educated about that, you're not going to participate. So we try to turn that all around. And one of the areas that we have focused heavily on is the Capital Breast Care Center mammograms. I don't know if people remember fighting to get mammography at the age of 50 reduced when you could start to the age of 40. We're seeing many blacks diagnosed under the age of 30, and yet they didn't want to have and offer mammography to people until they were 50. Those are issues that we have to constantly grapple with. But we also don't want women to get one mammogram and say, I've had a mammogram. So that focus has to be on adherence, mammography adherence. But we do provide mammograms to uninsured and underinsured individuals so that women can get that aspect of health taken care of. Annually, then we have the rules and regulations that come out that say it should be every year or every 2 years. We let people decide which one they want to go with, but we want to make certain people begin to adhere. So we have a whole community Capital Breast Care Center staff that really, in this little van, goes around and brings people in for their screening. So we try to do these outreach efforts. But while we're doing that, we're also trying to think about the research that we should devise that will address this issue and give us a chance to look at how to improve the intervention. How do we get people to come in and participate in mammography screening on a regular basis? How do we educate them? Is it the intervention? Is it the education? Do we need to have peer groups to intervene? Do we need to have a survivor to help get people to realize the importance of mammography? And we also do community grand rounds. And this is really helpful. I just picked the topic here, just as nutrition and cancer prevention, but we do them on clinical trials. Once we do these little community grand rounds, they could be in churches, they can be anywhere. They can be at a town hall meeting, at a residence house, but it's a topic that is of interest to the community, and it also is of interest to us, because if we can get people engaged in our community grand rounds, we can get them engaged in our science as well. Now, bringing it back from just what the outreach group does, just want to share with you, people talk about hard to reach people. That population is hard to reach. Those individuals are hard to reach. And I've never had that problem. And this paper that was published in 2016, Enrolling Minority and Underserved Population in Cancer Clinical Research, we clearly demonstrate that every study that we have opened, every clinical study, every clinical trial, any intervention, behavior intervention, we have always met our target. We have always accrued the individuals we said we would accrue. And that's because it does take money, because we have to use recruiters and outreach staff. But this paper does show that we have been successful in every endeavor for our research projects. And our research are based on population science and clinical trials. So as we go back to those slides I showed you earlier about just general risk factors for breast cancer or cancers in general, you'll see right here, moderate risk, modifiable and non-modifiable, but obesity and physical inactivity. These are modifiable risk factors, although many people think physical inactivity is not modifiable. It really is. You have to move to do a little bit better. And we talk about metabolic syndrome, 56% is increased risk, primarily among postmenopausal breast cancer. So my interest is in addressing and intervening on modifiable lifestyle factors. And you ask why? Because I think it's something that we can give to the community. It might solve the problem or reduce people's risk for cancer, but I guarantee you the factors that we are picking will also reduce the risk for other chronic diseases, whether it's diabetes, stroke, heart disease. So to me, it has a very broad reach, and I think it's very important. I mentioned metabolic syndrome, maybe a little bit out of order. When you think about metabolic syndrome, you think about these different components, whether it's waist circumference or waist circumference, triglycerides, cholesterol, glucose, blood pressure, and the metabolic syndrome is the clustering of these, at least 3 of these. But in Black populations, the lipid profile doesn't do anything. That's been published. So you really just need 2, abdominal girth and 2 factors total. So central obesity is a big issue, insulin resistance, and hypertension. Unfortunately, almost everybody can get in to having metabolic syndrome just based on hypertension. In certain populations, hypertension's prevalence rates are sky high. So this is a little schizophrenic diagram about metabolic syndrome, the obesity, waist circumference. And there's so many different pathways that lead us down to promote cancer development that I choose to look at the leptins and adiponectins, the insulin pathways. But you'll see there's so many pathways that are involved in metabolic syndrome. And so many people are inflicted with this disease. 20% higher risk of METs among black women compared to white women. And black-white female prevalence, look at this, waist circumference. Blacks are always at a higher rate for most of these variables. And I think that's a sad commentary, but sometimes I think of it, a lot of it has to do with the obesity issue. And now we're talking so much about childhood obesity. So what will happen in another 10 years? We'll see. I think it's going to be pretty bad. So the potential causes of disparities, you can probably name a dozen things, but I'll start with this. Used to be hunters and walkers and everything, but when you get to the end over here, looks like McDonald's or Burger King, and you notice the weight's going on and the obesity is coming. So is it evolutionary? Is this about evolution? You know the story about the remote control. If a person doesn't have the remote control, they can't change the TV because they will have to get up. And you become much more, you go from walking to being totally sedentary. And that's where we are pretty much right now. Uh-oh, my thing is not clicking. Hang on. So I typically call it weapons of mass expansion. And you notice that in certain neighborhoods, you will not find a McDonald's. You will not find a Taco Bell. But in other areas, you'll find all of these weapons of mass expansion. But they do sell healthy foods. You can buy a salad, but you just never, they make salads, you just never see anybody buy them. So it becomes different. Physical inactivity. The lighter the color, the more physically active people are. So you see down here in the southern area, not too physically active. But here on the West Coast people always talk about the nice weather, so they are pretty physically active. And if you look at it by race, you'll see for blacks, again, very high rates of physical inactivity. It's like people just can't win. But this is, to me, more damaging than anything else. If we look at self-reported obesity among non-Hispanic whites in the country, the darkest color is the high percent, greater than 35% of the population is obese. So you see right here, West Virginia. Keep in mind, that's the darkest color. But yet, when we go to blacks, do you see how the map changes? It's not one little dot on the map. It is a massive amount of states that have more than 35% of their population that's obese. Now, about 3 decades ago, these maps were all light blue and white, meaning there was no obesity. So what has changed in the past 3 decades? What has really changed? Food prices go up, but so does sugar content, fat content, portion sizes all go up. And what we have seen is physical activity. I'm just going to skip through a few things. Physical activity has been shown to be protective in terms of breast cancer. And if you look at some of the reports that have come out, strong evidence showing that physical activity decreases risk. You know, body fat is associated with increased risk. Now obesity is linked to many cancers, clearly with heart disease, clearly with diabetes, clearly with stroke. And if we would do a map of diabetes with obesity, they would be superimposed on each other. So what do we do? And that's always the question. So I've told you already, DC has one of the highest breast cancer incidence rates and mortality rates, and they have a huge, large disparity. But this type of pattern we can see across the country. Metabolic syndrome is also an independent risk factor for breast cancer. These are new things that have been emerging for the last few years. Metabolic syndrome and physical inactivity are highly prevalent in Black women, and there do exist structural and financial barriers. When you talk about exercise, do we talk about taking a walk in a neighborhood that might not be safe? Or do we talk about spending a lot of money to go to a gym? Or do we have a lot of gym memberships and we never go? You know, all those things come into play. So the premise that we have and we address is, would a short-term exercise intervention improve metabolic health in Black women at increased risk for breast cancer? And would the effect be similar if you did it at home alone or did it under supervision with an exercise physiologist? And this is what has led us to our study that we call FIERCE, Focused Intervention on Exercise to Reduce Cancer. And it was a grant awarded by the National Institute of Minority Health Disparities, and was done in conjunction with Georgetown and Howard University. And I was the PI of this study, and it's just ended, and we're publishing and have published papers on this already. So I will tell you about this study, and you'll see here, just showing you the thunderousness of metabolic syndrome, overweight, obesity, insulin, high blood pressure, and abnormal cholesterol levels. And here, more simplified metabolic syndrome and breast cancer, just showing the different pathways that are prevalent in use of the insulin, as I said before, that lead to cell proliferation. So this study is a behavioral intervention, it's a clinical trial, to compare the impact of a supervised, facility-based, and a home-based exercise intervention on obesity, metabolic syndrome components, and known breast cancer biomarkers in postmenopausal women who are metabolically unhealthy. And we say metabolically unhealthy because they have like 2 of the factors at least, but not 3, because lipids, as I said, do not really impact metabolic syndrome in Black populations, among women who are at increased risk for breast cancer. And if you can see the study design, it's a 3-arm trial with a control, supervised, home-based, and control. I'm just going to ask you at the very beginning to think about which group you think will do the best. Supervised, how many people would think supervised would be the best group? You know I can't see anyhow, so it's okay. What about home-based? Anybody think home-based would work? And the control, anybody think doing nothing will do well? Okay. Well, you'll see the 3 different groups here. And we told the control groups, if you were eating a lot, just keep eating, don't change anything, do what you normally do. The supervised group came in 3 times a week to our community-based office. They exercised. They were given a regimen to do with the exercise physiologist 3 times a week. The study lasted for 6 months. And home-based, we gave them a goal of 10,000 steps per day. People think that's a very simple task. I don't know if you all check your iPhones and push the little heart monitor and see how many steps you really walk a day. Maybe going to the shuttle or to the metro, you might do a lot. But then on the weekends, you probably look very sedentary compared to that. So we give them a little diary journal, 10,000 steps a week. And we also do a text message to give you a little goal motivation. We want you to, keep doing it. For the control group, they get a text message saying, try to keep a healthy lifestyle, but we want you to keep eating. We don't want you to miss about study, So this is our eligibility criteria. African American women, 45 to 65 years of age, postmenopausal. They have a 5-year individual breast cancer risk of 1.40, greater than 1.40, using the CARE model. Gale model and we've had many arguments about the Gale model, but the CARE model was a better one for us. And metabolically unhealthy, waist circumference greater than 35 inches, and at least one of the following, fasting glucose or blood pressure. Now, the interesting thing about this study is people get angry at me if they come to be in my study and I tell them that they're ineligible. And you don't want to invite people in and then tell them they have to go home, especially when you finally get people coming into clinical trials. But people are ineligible because they didn't meet the obesity requirement. I think that's a plus but that wasn't viewed that way. So we created other studies, almost like having a snowball effect. We had other studies available, so if they didn't meet the eligibility criteria, we had another exercise study ready to go for those individuals. So we wanted to make certain we offered things, because I remember with the breast cancer prevention trial, you could screen people when they finally are eligible. You think that they're going to be eligible. You put in race black, they're not eligible anymore. You put in race white, they're eligible. Different algorithms, different things. So we had to learn to try to build other programs. If they come in and they say they smoke, put them in a smoking cessation program, but have them do something to participate in clinical studies, because they already are willing to come to you. And that takes a lot of work. And exclusion, history of cancer, we took out people who had diabetes on purpose for this study. We figured it might cause too much complications for us. And lack of access to a mobile phone. People might not have a home or anything else, they have a mobile phone. People have phones. They can always reach out and talk to people or text with people, for the most part. The hardest part for this study was recruitment, so you would think. We used community health workers, we used our mammogram clinics, we used our church newsletters, neighborhood flyers, word of mouth, and community advisory council, and representatives in the community. And we came up with this little fancy little flyer or postcard that, we printed 6,000. We only needed to get about 220 people in to have adequate power and sample size. But we printed 6,000 of these because somebody talked me into printing 6,000. And we gave them all out. Can you imagine? We had different methods of giving them out. And one method that I didn't really know they were doing was putting a flyer or putting a postcard underneath somebody's windshield wiper. So they put it under the windshield wiper, and the lady called to the office and said, "How did you know I was fat?" "We didn't know you were fat." And she just said, "Oh, I'm just kidding. I got it. I want to come in." But I'm just saying, you just never know how people are going to respond when you get things. So I was like, at first I was like, oh my God, what do we do to this person? And we did different assessments, medical history and demographics, anthropometrics. We looked at your maximum VO2 consumption, food intake, quality of life, so a whole barrage of things. And we did all the fasting laboratory stuff, C-reactive protein, a whole lot of measurements we are doing. And we did assessments at baseline 3 and 6 months. People thought that this might not work. They said, oh, we'll never get the 220 people, 240 people we need, or get over 100. So just want you to know, we had to screen 1,500 people to get our numbers. But that was 1,500 people that were willing to come and be screened. But then when you tell them about the study, they might say 6 months, that's a long time. But you can see what eliminated people as well. In this next little slide, here's a consort showing just, we started with 1521 at the top. Our control group was 71, home base was 69, and supervised 73. And different reasons, and people didn't have phones that were connected, or they didn't complete baseline assessments. You want to make certain people are going to do certain things. If they don't complete the baseline, you really don't want them in a clinical trial to try to go to the finish line. Unfortunately, during this time, our major research coordinator also had developed cancer, breast cancer. And even when she was hospitalized, she was able to recruit people in the study because they really believed and trusted in her. They really, really, really enjoyed how she interfaced with them and made them feel very important about this study. So you'll see that we have recruited people, but we started with a very large number. And just to get to 1,500, at the outset, it took a huge staff to do this. Now, before, I had the Women's Health Initiative many years ago, and we were one of the minority recruitment sites. And I remember coming to NIH saying, well, for us to do this, we're going to have a huge recruitment team. And they're like, oh, no, just a person. And no, we ended up with 5, but we met our targets for being one of 40 Women Health Initiative sites, and we were one of 10 minority sites, but we were the first one to meet the minority accruals because we had set the infrastructure in place. And even for the basic scientists, I know that many of them, you want blood, you need specimens, you need some tissue, you need all these things, but there's a huge amount of work that goes into getting that information for you. And I think it's really important to understand that even when you create a basic science project, you need to be able to recruit people to get the specimens that are needed, and I think that's often overlooked in many studies. So just if you take a quick look at this change in metabolic syndrome over 6 months of exercise intervention, and our exercise was not strenuous, but we had people, they had to keep increasing their rates, and we did a lot of measures on them. And you'll see the control group, thank goodness, they did poorly as we expected. And our home-based group did the best. You see the decline over 6 months. The supervised was still declining, improving, but the home-based, what was it about the home-based group? Is it the fact that they took a lot of pride in it, they felt that they were competing or something? Or was it the access? It was right there. You know, even if you just run up and down the steps several times, you're going to improve your step. Don't take the elevator. We gave a lot of tips of what not to do, what to do. The home-based group really got it. In fact, after the study, I'm going to just divert for a minute. After the study, I started seeing people come into the office, and I couldn't understand why they were coming in, because I know where we started. One woman had lost 100 pounds because, this is after the study ended though, because she said she just loved learning that she should be able to move more and finding confidence in herself to go forward and do more. So the home-based did better than the supervised group. So the only problem I have with this is I have an exercise room at Georgetown, and I don't want them to take it from me, because we can show that the home base is very, very, very good. And then if you look at it here, if you look at it by no family history, you still see a decrease in the home base and slightly in the supervised group. But when you look at it by family history of breast cancer, you see a much more dramatic decrease in home-based group. And what this means is we probably need to target, or we could easily target people that should have the intervention that will get the best gain. It's no different than for people who smoke. You're like, everybody who smokes doesn't get lung cancer. Who do you target as your highest risk group, even though I think that nobody should smoke, but who do you target as your highest risk group for a behavior intervention? So here we were able to show with the family history, we were able to improve just by exercise intervention. And if we look at the care model here, those who have the highest care model score, over here, you still see a big improvement between the baseline and follow-up for the home-based group. So the home-based group really has a lot of things going on that are very favorable. And I think coming to any facility 3 times a week, we're down by the Washington National Stadium. There are game days that we can't have you come down because you'll never get in, you'll never be able to park. So there are different things that really impact coming to a facility, coming to an exercise place. So we're going to try to do more with the home-based approach, even though we do need to have validations and certain measures done in-house all the time. We decided to take a little turn for a minute and look at allostatic load, that disease, that burden from the stress on the whole body. And, you know, things that burden people, jobs, life changes, relationships. And here you see that term allostatic load. It can be internal stress, external stress. So we just decided to take another look, almost like a repurposing of our fear study, to look and see how does stress look in this population. And when you look at it, you'll see that you have perceived stress, behavioral responses, different individual differences such as genes, physiological responses, the environment here, but it all plays a role in this term of allostatic load, that burden that's placed on the whole physical system because of many stressors, internal and external. And if you look at the path from psychosocial stress to disease, you'll see you have chronic stress can result in disease. Sometimes we put physical science, we talk about biological science, and we forget about the behavior or the mental or the psychosocial. And we just show that it can all flow together. And sometimes we isolate more than we need to, but we have a chance to look a little bit more at some of the stressors in this population. And think about stress mediation. Some primary mediators are into neuroendocrine system. Then secondary, the immune, and we were looking mostly from the metabolic, cardiovascular, as well as the anthropometric. Okay. So our aims for this little repurposing was to determine if physical activity can reduce allostatic load in really metabolically unhealthy African American women who are at increased risk of breast cancer. If we think stress plays a role, perhaps that's going to happen here. And then to address the relationship between allostatic load and some selected cancer risk factors. Here you'll just see a little list very quickly of some of the variables, and you see they look so similar to metabolic syndrome other than you have C-reactive protein in here. But there's so many measures you can use. We looked up there about 26 ways of looking at allostatic load, and there's so many markers. They suggest that you look at least 7 components for allostatic load, which we were trying to do. And then we decided to take a Z score of the allostatic load, just so that we could have comparable data to compare to other people if they're using a Z score. So it's not just apples versus oranges, but apples to apples. I'm not going to do the math today. I don't know what's happening with this. And here, you'll see that my little slide's off. For the allostatic load, the burden was definitely, the Z score mean was higher in the blue, which is the control group, compared to the other 2 groups. I'm having trouble with this one. And here, looking at by family history and breast cancer, you're going to see the exact same patterns that we saw in the other groups as well for metabolic syndrome. So we know metabolic syndrome and allostatic load are so connected, but we do get a chance to look at some of the other stress markers, and we're working on that right now to do more of the assays. And if you look here, you'll see that there's a benefit with the supervised group at baseline. From baseline, the supervised group is lower, and then 6 months, you'll see supervised group did the best. So it's not home-based here, it's supervised. We don't know why that changes. Am I not pointing right? And just very quickly, thinking about the barriers to participation, just in any studies in general, I think we should all think about this. Your study design, what the intervention is, create an intervention that people want to do. Like I might say, let's go out and run 5 miles. They'll say no. You might say, let's go walk 5,000 steps. And you want to go to 10,000 steps, but if you can just get people to do more than they've been doing. We were able to show, with, even though I'm not presenting that today, the VO2 max is improved. We do DEXAs on people, so you can look at the body composition. A woman got really mad at one of the physicians because they had done everything we had asked them to do, and they weighed exactly the same. But with the DEXA machine, we could show them that their fat had now been converted to muscle, and they had improved. So that would help so much. We can look at some of the awareness of some of the barriers, and I think awareness is very important to me. If you make people aware of what's going on, aware of the studies, aware of the education that you need to parlay to them, you give people an opportunity to participate. And look and see how your acceptance and refusals are. Those are what measures of success. So if there's awareness, there's education, there's an opportunity presented, then I think you can begin to measure success in communities that we often hear say hard to reach, and I think they're just go-get-them communities. And when you go get them and invite them in, you'll find out that you can do much more. The other missing variable in general is cultural competence. If I ask people, and I'm not asking anybody, I ask people how many people think they need cultural competence training, probably nobody will say yes. I think everybody does. Not one group, not one ethnic group. I think everybody does, because I think sometimes this is a major missing variable that we often overlook. You know, we might just casually say, oh, that's silly, but saying that statement to somebody could be so damaging. So there's a lot to be gained there. And when you think about cultural competence, I think it's really important that we understand and value diversity. We do conduct self-assessments of where we are. We manage the dynamics of our differences. We don't all think alike, nor do we want to think alike, but we have to manage our differences. And we need to acquire cultural knowledge. And we have to adapt to the diversity and cultural context of individuals and communities. And I can tell you, communities are very diverse, even within different ethnic groups. They are very diverse, and you have to know a little bit about what's happening or have people from your community work with you so that you can move forward. So just in short conclusion, the short-term exercise intervention does reduce metabolic syndrome. Both supervised and home-based did better, and the benefits seem to be independent of weight loss, and I think that's a very important factor. You don't always have to lose weight to improve your health profile. Your biomarkers can improve. Your physique can improve in terms of having muscle instead of fat. There are many things that can benefit, and that's independent of weight loss. And allostatic load, a marker of chronic physiologic stress, was also reduced among the exercise compared to the control group. So again, I hope we'll try to strive for equity. And equity for me means including many people in studies that are can really benefit from being involved in clinical trials. I really am a strong promoter of clinical trials, behavior interventions, because there's so many things, so many variables that are modifiable. And even if we talk about treatment trials, we need to make certain that we get people in, and we have to think of people as people. They're not the engineered mouse that you can say, give me breast cancer, and you just have breast cancer. You have to look at that whole dynamic with somebody who has cancer and diabetes and maybe heart problems, but we have to be able to treat everybody. So I just strive for equity, strive to offer precision medicine, precision studies, precision interventions, so that we can at least come to, these are too close to me, at least come to some place where everybody is going to begin to have a decline in their diseases, not just one group, but everybody. So I think we should be much more inclusive than we are. I'm failing on this little. And I just want to acknowledge the staff that I had from Howard University, University of Maryland, and from Georgetown, and to the late Vivian Watkins, who was our research coordinator, who died this not long ago. Well, my last slide, I think, but I surely can't turn it. Hang on. That's it. Thank you.
So thanks very much. We have time for questions. So there are people who might want to come to microphones in the aisle, starting right over here. Yes, sir.
You mentioned that you eliminated people from the study based on the fact whether or not they had a cell phone or communication. I'm wondering if that was really a missed opportunity, because some people prefer not to have a cell phone, and that in and of itself might be a factor that shows people, even though they have metabolic syndrome, might be more receptive to the type of training because they're not as distracted, or they don't have a cell phone, etc. In other words, is a cell phone a factor in terms of being susceptible to breast cancer? So I would suggest, just as a suggestion, maybe you think this is foolish or silly, but maybe perhaps those that don't have cell phones, what you could do is furnish and train them to have proper communication, and perhaps you would get a different result. Maybe they'll be the most successful. And then you could show, hey, the cell phone essentially causes breast cancer or predisposes to breast cancer. Now that might be something you're not interested in, but I just thought I'd suggest it. Thank you.
Thank you. The issue about the cell phone was for a different purpose. When you go through study sections at NIH and you have different intervention groups, behavior interventions, they want to make certain that the same amount of contact hours and time is given at each group so that there will not be a differential. So we had to have, if we're going to give text messages as our method of delivery for the phones, we had to have people having the cell phone so that we can use text messaging. What you're saying is a different question that we were not asking. But yes, your point's well taken, but we still did not, I don't think, lost anything, because I don't think we had a whole lot of people who didn't have cell phones, the reality.
Okay, thank you.
Over here.
Great. Thank you so much for an excellent presentation. And just thinking of my cell phone, if I didn't have it, I think my allostatic load would certainly go down and the health behaviors would improve. I'd like to talk about prevention. I'm an endocrinologist, and it used to be very rare before that I would see a child come in with type 2 diabetes. So now we're seeing higher incidence, again, the issues of obesity, the lack of exercise. Can we talk about some of your interventions and maybe how we could gear them towards younger generations, especially young female and women or young girls across all different cultural divides?
Well, first of all, I think that Michelle Obama's movement was very important to get everybody moving. Obesity is a huge problem for the children. We definitely agree with that. And some of the things we're talking about are prohibited because of the schools that people go to. You know, when I was in school here in D.C., you had physical education every day. That's one of the first things they cut out because they don't want to have the teachers. They don't want to pay for the teaching. So I think it's coming back, but not on a regular basis. But I do think that we could do things, and those video games, we had a grant from NIH called Exergaming. And children really could benefit if they played the exergaming that required them to move. There are different types, not the ones you just sit and stand still. But we did this on the adult population. I think that's translatable. But also, I think we're going to have more physical education. To me, that's the only way to really get it going, and to do more family studies. It's hard to tell some child to go out and do something when the parents are looking at every TV show from sunup to sundown.
So in your families that were at high risk, is it possible to look at the generational approach, go to the moms and see if their kids actually may be starting to improve their nutrition and physical activity patterns? Do we see that intersection?
Absolutely. And we have been doing nutrition studies, and we are currently working on family studies because we think that how we pick that program, is the program really the child, or at least have the child involved in the study? And that's where we are seriously right now. And we're doing a study with somebody in my office is doing a study with the Human Genome Center, just trying to focus on family risks, what can be done. And I'm interested in the modifiable variable. So yes, I think that's a good thing, and I think that we need to start much younger. And before, you know, everybody doesn't have to do organized sports, but we need to do something organized so that we can get the children involved and engaged. And I think people would really play if they had safe places, too.
Yes, sir.
Hi, I'm Courtney Fitzhugh, and I research involves sickle cell disease, so it's primarily an African-American disease. And I just want to congratulate you. I really liked how you talked about, you know, that you're able to recruit 1,500 patients. I know that was a lot more than you expected, but I just really think that's an important point about the importance of going to the communities where the patients are and that they will be involved. And you also talked about trust. Spending that time building up the trust has been, so I just think those are really two important points, so thank you.
Thank you. I think when I left Howard, after being at Howard University for 18 years, and going to Georgetown, I think Georgetown thought it would be a piece of cake because I already knew all the communities. And my perspective was I want to start from ground zero at Georgetown because I represent a different entity now. And yes, it was easy for me, but you know there was still a little blowback that I left the HBCU to go to majority school, but still the community really rallied around what we were doing, and they could see that we were being very, very serious. The fact that I have a 10 or 15-year lease out in the community that I don't think Georgetown had planned to buy initially, but we're there, that we become part of the fabric. And I think being part of the fabric is a very different model than being a helicopter science where you swirl in to the community, grab the specimens, and swirl out. And we don't do that. And we make certain that even though we're a cancer-focused group, somebody might say, we want you to come out and measure our blood pressure for us. We'll do that too, because we have to give back to the community what they need, and they stay totally engaged with us. And I think it's because of the Community Advisory Council. They are very important, very key people, not only the leaders, but everybody that's involved plays a major role.
Yes.
Hi, thank you very much for your talk. I very much enjoyed it. You showed a flow chart on how to get more engagement, like recruitment. And I was wondering, to what extent do you discuss this with other researchers and perhaps train other researchers who may say that it is very difficult to get these various communities on board?
The fact that I'm the Associate Director for Minority Health Disparities Research gives me an entree to every program. I sit at every executive committee meeting, and we talk about it. And when people are designing studies and planning studies, even if it's my staff, you're going to write people in that will actually do it, the work, and help you make your project successful. But I don't want people to put grants in that need that component and they don't include it and forget about it. And then when they get funded, oh, we can't get the population, can you help us? So we do it proactively, and it's part of our center function at Georgetown. The community outreach and engagement is a viable and official component of the Cancer Center, so we do play a major role. And I, from the health disparities perspective, represent the cross-cutting component to the Cancer Center. So health disparities is addressed across the board, so I can talk to the program leader for experimental therapeutics, or I can talk to the program leader for molecular oncology and talk about the different sciences that are being done and who the population they want to secure specimens from or engage them. And we do play a major role in all of those activities. I don't think it can be done any other way.
Thank you.
But I don't do everything. I have a lot of people who do. I don't.
Let me ask you one last question. Oh, well, no, go ahead.
Okay. Hi, my name is Hannah Buhai. I'm a postback here. First, I really want to say I really, really enjoyed this. It kind of encompasses what I want to do, and it was a pleasure to see you speak. My question is, what are some barriers that you see that are currently in place that hold back outreach from being as critical of a component, or to the degree that it needs to be implemented in, so that clinical research has the impact it can truly have on certain communities, marginalized communities or communities of color?
The biggest barrier, I think education is one of the biggest barriers, and money, those two, money. You have to have money to do all these things. Resources are very important, but education is, to me, very important. We make certain that whether we conduct focus groups to find out where people are, because it's important for us to know, okay, they don't know anything about this topic. How do we bridge the gap? How do we tell them about it? We have a study called Breast Cancer Environmental Research Project, which looks at heavy metals and relationship to mammographic density. And it's because people are living around what used to be a Superfund site. So we're cutting 10 toenail clippings from each woman and looking at cadmium and arsenic and all these things. But we couldn't get them involved in heavy metals unless they really understood it. But then when they understood it, they rallied to make certain that we can accrue the population. So it's all about educating people and bringing them to the table. So like the community grand rounds I said, yes, we do community grand rounds on these different topics to help educate. And then they ask for more. They'll invite us to a church to come. Can you come and talk to us a little bit more about something? All those are important, and get different physicians to go out, get different lay people to go out, and get people to go out in pairs. I might go out with the exercise physiologist or the nutritionist, and they give different components. You know, like my nutritionist almost got killed, literally in a sense, because she told people, she was at some community outreach, you shouldn't eat hot dogs. Well, people love hot dogs, so she will never use that as an example again.
Last question I wanted to ask. When you showed the data about response to your home-based intervention, which is pretty intriguing that it worked the way that it did, it seemed to work particularly well for the people with a positive family history. And that sort of makes you wonder, well, wait a minute, what's going on here? I doubt that somehow their genetic predisposition to breast cancer had a biological effect on their brain that made them more likely to adhere to your home-based system. I assume instead maybe they were more motivated because they had a higher concern about this disease. Is that what your understanding is? And were you able to quantify their level of concern as something that might be predictive of response?
That grant's being submitted June 5th. But the idea is we do feel, in general, if somebody in your family has cancer, and cancer is not a little c, people view it as a big C. If people have cancer, they are often more motivated to do more than other people will. But we didn't recruit people who had cancer. We recruited people, and we didn't even say, we told the variables we were going to collect, but we didn't even talk about, we're going to look at your risk of breast cancer in relationship to this. We never brought that up. Actually, to be honest, when we were working to publish the paper in Cancer Journal, we had forgotten about our risk assessment. And once we went back and looked at our risk assessment, everything came out in the right direction. We were looking at it without that breast cancer risk. So clearly, we forgot about it, so we know the community didn't even think about it. So I think it was just motivation.
That's interesting. Well, we're going to have a reception in the medical library for those of you who'd like to continue the conversation over coffee and cookies. And meanwhile, please join me in thanking Professor Adams-Campbell again.